Welcome to this presentation by Dr. Larry Bramlage on the use of bisphosphonates and the implication for their use in racehorses. Dr. Larry Bramlage is a world-renowned surgeon at Rood & Riddle in Lexington, Kentucky. He is a graduate of the Kansas State University College of Veterinary Medicine and received his master's degree from the Ohio State University, where he taught equine surgery prior to entering private practice. Dr. Bramlage has published over 70 scientific articles on equine surgery and was a longtime voice of the American Association of Equine Practitioners on-call program. Dr. Bramlage is board certified by the American College of Veterinary Surgeons.
So what are bisphosphonates and what do they do? They're drugs developed for use for osteoporosis in women. There are two that have been approved for limited use in the horse, Osphos and Tildren. To understand bisphosphonates, we need to understand a little bit about bone. There are three main processes that are going on in bone. One, you add bone to the end, and that results in growth. Two, you can add bone to the outside of existing bones, and that's called modeling. Or you can change the structure or the shape of the bone from within, and that's called remodeling. Growth obviously happens in the immature skeleton, but modeling and remodeling are going on all the time in all skeletons. When bone is growing, modeling, or remodeling, or for that matter, healing, there are three cell types that are doing the work. Osteoblasts are the bone builders, osteoclasts are the bone removers, and osteocytes are the controllers of the processes that are going on, and they orchestrate the other two types of cells and tell them what to do. Remodeling in bone is an interesting process. It's done by what are called bone remodeling units, or sometimes short-termed cutting cones. They're little tunneling units that cut canals through the old bone and lay down new rejuvenated bone. As you can see from the illustration, the canals are cut by the osteoclasts, the red cells. They digest the bone and allow the process to start. The hole that they form is then filled by the osteoblasts, which are the bone-forming cells. Those are the green cells in the illustration. Osteoblasts are caught up in the matrix that they're laying down, and once they get trapped inside the bone, their function changes. They change to osteocytes, or the directors of the process for the ongoing renewal and remodeling of bone. One of the tools we use to assess bone formation in the horse is the bone scan, or nuclear scintigraphy. The radioactive dye actually labels new bone production. That new bone production may be the result of growth, as is indicated in this bone scan by the hot spots on the ends of the bone, or by bone repair, as can be seen in the bottom row where the arrow points to a tibial stress fracture, which is requiring membranous bone to be laid down to repair that tibial stress fracture. The anatomic picture of the bone, or the shape that we can recognize on the pictures of the bone scan, is the result of the remodeling process. These cutting cones are active enough that in only 3 hours of removal and readdition of bone, we can see what the bone anatomically looks like. Bone remodeling units remove old or damaged bone and replace it with new bone by creating what are called secondary osteons, which are actually just columns of new bone. The illustration on the left-hand side is a drawing of how that happens, but on the right-hand side is a histopath slide of bone, which shows secondary osteons cut transversely. All of those brown columns of bone are new secondary osteons. They're brown because they're less fully calcified than the old white bone. The white bone is the old bone. Because they're less brittle, newer, and less fully calcified, they're able to absorb the stress of exercise or weight bearing much better than the old brittle bone. The insertion of secondary osteons actually has several functions. We've already mentioned the fact that new bone, which is the brown bone in this slide, is less fully mineralized. The crystals are less mature, and so it's a little bit more ductile, or it can bend a little bit. The white bone in this slide is fully mineralized. Those crystals will be much stiffer, and they're much less able to bend and absorb stress. Secondary osteons also have another important function. They will arrest small cracks from normal wear and tear that occur within bone. This illustration has two small cracks within the substance of the bone. They're illustrated by the two arrows. You can see the secondary osteons have stopped those cracks from propagating through the bone. They interrupt the microfractures, which then become stress fractures, which then become gross fractures within bone if something's not done. It's the secondary osteons that stop those small cracks from becoming big cracks and eventually fractures. We've already covered secondary osteons, or the remodeling of bone. Now we need to say a few words about modeling. Modeling is done by adding primary osteons to the surface of the bone. The best illustration of this is a horse's cannon bone, which is shown in the lower left-hand picture, where it started out with a circular yearling cannon bone. And race training has caused the horse to add all of that new bone on the outside in the places where it's best positioned to withstand the stress of racing and training. All of this process is guided by the osteocyte, which are osteoblasts that are trapped in the bone. That little green box shows an osteocyte. Sort of looks like a centipede with lots of little fingers sticking out from the cell body and communicating with other osteocytes. For many years, bone was thought to be inert, but it's actually a very active living organ. The green cells in the middle of the slide are osteocytes. All the mineral has been digested to show their dendrites, or little cellular extensions, that extend from one osteocyte to the other through little canaliculi, or canals, within the bone. All of the osteocytes are communicating with each other and sensing the loads seen by the bone. They also control the internal bone metabolism in many different ways. Osteocytes, which are actually osteoblasts that have become walled into the bone, sense the biomechanical loads on the bone through the canaliculi and dendrites that interconnect the cells. They then control the formation and absorption of bone via these connections. They'll cause primary osteons to be added to the surface of the bone. They also cause the internal remodeling to occur. In addition, they control other processes, such as making calcium available to maintain calcium balance throughout the horse's body. Finally, we get to the third type of cell, the osteoclast, whose job it is to remove damaged or dead bone. Then that allows new bone to be laid in the area where the dead bone was removed. This is the interior of a bone, and it shows an area of dead bone, the arrow in the bottom of the slide, and an area of live bone, the arrow on the left-hand side of the slide. The live bone has live cells within the osteocyte lacunae. The osteoclast is digesting the dead bone. That's its job. Conceptually, osteoclasts are always looking for an excuse to remodel bone. They're kept at bay in healthy bone by the osteocytes and those dendrites, those little finger-like projections that we were looking at earlier in the slide. If you damage the osteocyte connections, or those dendrites, or harm the cell, the osteocytes no longer keep the osteoclast at bay. the osteoclast invade, remove the damaged bone or the inferior bone, and insert new, healthy, stronger, viable bone. That's how the renewal process knows which bone to replace because it's damaged and which areas of fatigue fractures need to be reinforced. It's the damage to the osteocytes that allows the osteoclasts to come in and remove that damaged bone. So how does all this discussion of cells relate to the horse, lameness, bone remodeling, and the clinical situation? This slide shows a condylar fracture in the lower left-hand corner. Next to it is the immediate post-op picture where the condylar fracture has been compressed by the two screws. The fracture disappears on the radiographs. This is our goal with surgery. But in actual fact, the fracture will look something like the blue-green picture in the middle. The fracture is still there. It has to be repaired and bridged. The first step in repairing this fracture is to fill that gap with woven bone. That's illustrated in the lower right-hand corner. Woven bone is disorganized and weak, but it can be produced very fast. So it's the first step in the healing process. Most fractures are bridged with woven bone. That woven bone is then replaced with lamellar bone, which is highly organized and oriented to counteract the stresses seen by the bone. The osteocytes direct this process. Lamellar bone is very strong both because of its structure and because of its orientation. In most healing processes, the first step is the woven bone, and then that bone is removed and replaced with lamellar bone. Now let's go back to the condylar fracture we looked at previously. This is a little more illustrative sequence of the fracture repair. Fracture is reduced, stabilized, compressed, disappears on the radiographs, and then the crack is filled with woven bone. If you advance 5 months, you can see that white line of woven bone within the substance of the bone. That's where the fracture was repaired and now is being remodeled into lamellar bone. So what does this have to do with bisphosphonates? Well, bisphosphonates kill osteoclasts. So they will disable bone remodeling. They'll also disable the second phase of bone healing, where the osteoclasts are supposed to remove the woven bone and allow the lamellar bone to be produced. So one arm of the healing process is stopped. Drug companies are very careful to label this for use in older horses, but they're very willing to sell it for use in young training horses. That's where we run into the most problem, where the bone has to make the most adjustment to the consequences of exercise. So what good is a drug that kills osteoclasts? Well, it was developed for postmenopausal women with osteoporosis, weakened vertebrae, and the dowager's hump that we see in women that don't get enough exercise. Exercise is a much stronger stimulus for bone formation than is the hormonal change. So if you exercise a lot, you don't have to worry about the dowager's hump. But in people who don't get enough exercise, the bisphosphonates help slow the loss of bone strength. Bisphosphonates are also used in bone tumors because they relieve pain. That's specific pain relief for the bone, not centrally blocking the pain in the head, but rather eliminating the pain at the level of the bone. The mechanism is poorly understood, but it's well documented. So why would you consider using bisphosphonates in a young training horse or in a yearling? It's labeled for horses for navicular disease 5 years old and older. The reason is pain relief. It reduces the bone pain non-specifically. You don't even have to know where the horse is lame, but really sometimes you should know where the horse is lame. Published studies show mild pain relief in navicular disease and tarsal arthritis. And some people think it improves the radiographic appearance of bone in sesamoiditis, which I think is a questionable assumption, at least in my experience. The short-term benefit of the pain relief from bisphosphonates, which lasts roughly 30 days, has a very big long-term price. The detrimental effect on bone healing and remodeling lasts many months, perhaps years. Bisphosphonates attach to the mineralized surfaces on the interior of the bone. And when an osteoclast eats the bisphosphonate in its process of remodeling the bone, it kills the cell and the remodeling process stops. Bisphosphonates have never been shown to improve bone healing in any species. In fact, they disable what is one of the most important phases of bone healing, especially when you're trying to get a racehorse skeleton and make the bone strong again. So now some clinical examples to illustrate the concerns. Here's another condylar fracture, which you can see on the left-hand picture is day 0. Fracture's been compressed and reduced by the 2 screws, and the follow-up x-rays at 60 days show the white line we talked about before at the upper part of the condylar fracture. And at the bottom of the condylar fracture, it shows a darker line. Membranous bone is not as strong as subchondral bone, the bone near the joint. So it shows up as very white up high because it has a lot of mineral in it. And it shows up as very dark down low because it's not very strong. It's the same bone, but the bone around it is considerably different. Now at 60 days, we've turned this horse out and rechecked these radiographs at 90 days. At 90 days, you can see that the normal healing process has converted the cortical bone or the subchondral bone down near the joint back to almost normal subchondral bone. This is our goal. And the very thin, dense white line in the upper part of the fracture is beginning to fade out. That's all the process of the osteoclast removing the membranous bone and replacing it with lamellar bone. This is normal condylar fracture healing. This is what we want. This is an illustration of healing in a condylar fracture in a horse that's had bisphosphonates. This is 1 year post-fracture. The first thing you can see is the upper arrow shows a very wide, large area of dense mineralized bone. This is membranous bone that's reinforcing the fracture, but's not able to be remodeled because there are no osteoclasts. The fracture down near the joint doesn't look like normal subchondral bone like in the previous fracture. The membranous bone has continued to get more and more dense because it's trying to get stronger, but it can't remodel and it can't become normal bone again because it doesn't have any osteoclasts to remove that inferior quality bone and allow the lamellar bone to be formed. This is a year, and the horse is still unable to remodel his condylar fracture. Without all 3 functioning cell types, the bone renewal process can't function. On the right is a dorsal cortical stress fracture 14 months post-fracture occurrence and surgery. You can see that the bone has thickened and added osteons to the surface. The fracture and the associated drill holes for treatment have filled in with woven bone, but the horse can't reorganize that woven bone and convert it to cortical bone. Normally, we would expect that process to take 3 to 4 months, and this is 14 months post-injury, and you can still see the stress fracture within the cortex of the dorsal cannon bone. So how do people get away with using bisphosphonates? Well, the horse can still model bone. That is, they can add bone to the surface, both exterior and interior, at the site of an injury. But the quality of the bone begins to deteriorate because they can't remodel it, either at the injury or throughout the skeleton. So the entire skeleton begins to accumulate wear and tear. And at areas where they cannot enlarge the bone, they can't strengthen it. Where would that be? Principally at joint surfaces. You can't add bone to the surface of a joint because it changes the shape of the bone at the joint, and that's not functional. So injuries at the joint surface are particularly disabled from healing themselves, or healing in any short period of time because the osteoclast can't remove the damaged bone and replace it with high-quality lamellar bone. This is a horse with bruising to the distal cannon bone and a hind limb. Research has shown that we would expect this remodeling to heal the distal cannon bone in 2 to 3 months. But here we have follow-up x-rays at 45 days and at 90 days, and it shows nothing happening. The horse is able to lay in the woven bone into the injured area, but he can't remove the woven bone and change it to lamellar bone to make the distal cannon bone look like the original cannon bone or the trained cannon bone without the injury. This is a front cannon bone with a fine fissure fracture on the parasagittal groove marked with the arrow. This horse was lame and blocked to this area at day 0. Normally we would expect healing to be again in 2 to 3 months, but he was still lame and blocked to this area at 2 months, still lame and blocked to this area at 6 months, still lame and blocked to this area at 7 months. As you can see, the bone is changing, but it can't really remodel. There's no means of taking out the injured bone and replacing it with the stronger lamellar bone. This is a horse's third carpal bone. Again, the lameness blocks to this area, but after 60 days, he's added in some bone, but he hasn't been able to remodel the areas of bone inflammation that we normally would expect to be remodeled at about 2 months post-injury. So why do we care? Well, since bisphosphonates have come into use, I believe we see an increasing occurrence of poor healing and poor remodeling of injuries in horses. The bone doesn't remodel, and the horses stay lame longer. Things that used to take a couple of months to heal are now taking 3 to 4 months. Sometimes the effect of the bisphosphonates can last a year. The horses can fill a gap with bone, but they can't reorganize it, so it remains weaker, prone to injury, and often still causes lameness. In the cannon bone bruising study we did, 75% of horses took 60 days of paddock turnout to heal their bruises, and 25% took 90 days, but 95% of them returned to race. I don't think we can depend on that guideline any longer. I suspect the use of bisphosphonates far exceeds prudence.
Thank you for watching.